things that we do here regularly at Pacific Healing and Wellness, I work with Dr. Sandra Goins to assist in the procedures using diagnostic ultrasound. So what we do is we are able to look at a structure and put a needle right next to that structure. Now that's been a game changer when we started thinking about nerves, because with musculoskeletal ultrasound we can see nerves more clearly than we can with other imaging modalities. So we have the ability to see nerves, we have the ability to see something going directly at the nerve. So we can take a nerve that's compressed or a nerve that's not able to move through the connective tissue, and we can push the connective tissue off of the nerve so they can move more freely and get more effective circulation, typically improving function immediately in that nerve. And when I'm saying improving function, increasing sensation and decreasing or eliminating paralysis of that nerve. So if hydrodissection is going to be effective, the nerve is not severely damaged, it's just compressed. So in the world of neuromusculoskeletal, orthopedic, rehabilitative healthcare, the idea of decompressing a peripheral nerve is relatively new without an open surgery. So the typical way to address a nerve would be that's compressed in the connective tissue and not functioning would be to take a scalpel and cut down and cut everything off the nerve, which can be beneficial for a short period of time, but it tends not to be lasting. And because to explain that, I'd like to explain a little bit about adhesion. So if you think of whenever you damage something like your skin and it tries to heal, your body throws out webs, and for somehow when you see that thing healing, that part of your body healing, it seems like things get pulled back together. So you have these webs of fibers that go out and pull things and stitch things together. So if there's been an injury, that makes a lot of sense that would happen, because we want our skin and our structures to be stitched back together. If there's inflammation and that reaction of those fiber formations occurs, and there's a nerve nearby, the nerve may become adhered or may lose its ability to move through the connective tissue without losing function or being irritated. So with hydrodissection we can use fluid rather than scalpel, directed very carefully with a small gauge needle to push the connective tissue off of the nerve. So we're making a structural change with an injection where we achieve more space on the nerve. So you can see here on the screen here, you can see this is a needle, a very small gauge needle. This screen is, the full picture is 2 centimeters, so it's a very enlarged image. So you can see this needle coming, and it's right next to the nerve. This is on a video loop, so you see the needle kind of. What's happened is we had the needle down below the nerve. This is actually the C6 nerve root. This is the C6 transverse process. So this is in the front of the neck, and you can see how we've created this gap of fluid on the bottom side of the nerve and the top side of the nerve. In this case, this is the nerve root. So that effectively decompresses the nerve and allows the nerve to move more freely throughout the neck. Now what we do see on a regular basis is major changes happening for people's lives because of this. Now C6, a lot of times we'll hydrodissect C6 for people that have winged scapula, or they have median nerve pain or radial nerve pain or carpal tunnel, because those nerves are an extension of C6, at least part of those nerves. So when we decompress the nerve where it is most compressed, then we can change function significantly. Now what we typically see every week is somebody getting rid of or eliminating the paralysis of their stratus anterior, so getting rid of that winged scapula. We see somebody get their grip strength back. We see somebody with a paralyzed diaphragm able to breathe evenly again. So there's this major changes that we can make with hydrodissection. It's a field, that's changes that we're making in people's lives that really are not addressed by other forms of healthcare. So you think, well, what kind of practitioners, what kind of doctors are doing hydrodissection? And the answer is every kind of doctor that works with nerves, muscles, tendons, and bones. So, as we teach these things internationally, I've taught internationally for years. We're teaching orthopedic surgeons, we're teaching neurologists, we're teaching pain management, we're teaching even chiropractors, we're teaching PM&R or doctors, and we're teaching rheumatologists along with some physical therapists. So we're kind of covering that field of need. Now that said, there's definitely less than 1% of practitioners, of doctors out there that are skilled at doing hydrodissection, and probably less than 0.1% that are skilled at doing hydrodissection in the front of the neck. So this is kind of the higher level of just anatomical knowledge, higher level of skills. You don't, so far as your needle has to be right where you want it to make an effective and safe change in these nerves in the neck, which are important nerves because they can control everything, but from your digestion to your arms, your diaphragm, even your organ function. So let's take a look at what we typically see on a weekly basis. Well, sciatica is one of the things we see on a regular basis. Carpal tunnel is something we see on a regular basis. So all this technology of pushing the connective tissue off the nerve can be applied to the nerve roots that become the sciatic nerve, to the sciatic nerve directly, to the nerve roots that become the median nerve directly. The median nerve would be in the carpal tunnel. The sciatic nerve would be that pain going down the legs. Now there's a couple of the nerves that cause pain on the legs as well. So we do address those. For the layman, people tend to call pain shooting down their legs sciatica. There could be also an issue with the posterior cutaneous thigh nerve, or the obturator nerve, or the femoral nerve. And then even in this, it's the split of the sciatic nerve and the peroneal nerve, the sural nerves, or the tibial nerve. So we have a lot of nerves that, as anatomical specialists in musculoskeletal ultrasound, we have the ability to look at, isolate. Now what you're seeing on the screen here is a cross section of the nerve. So you're not seeing the nerve in long axis. So it's like the nerve is cut. So like if you cut a shoelace. Now if you notice, that nerve is not as small as you might think a nerve root might be. So you can see that's about 3 or 4 tenths of a centimeter, in cross-sectional diameter. Another reason I can say that is you look over to the side here, you can see, and I can measure that directly exactly. This is 1 centimeter and this is 2 centimeters. So that nerve is probably like 3 to 4 tenths of a centimeter in cross-sectional diameter versus, maybe 3 tenths of a centimeter in shorter axis diameter. So this hydrodissection of the cervical nerve roots is it's a game changer for a lot of people. But hydrodissection of nerves in any part of the body, wherever the nerve is compressed, is a game changer. So the question is the nerve compressed within connective tissue? Is the nerve compressed within the spine? Is the nerve compressed proximally by the nerve root, or is it compressed distally? And 3 years of study and working in the field, we've developed and understandings of places that nerves typically get compressed. So you can kind of trace a nerve down, see where it's the most compressed, and decompress it at that area, and instantaneously we know we either got it right or wrong, because the symptoms are better, the function is better, the pain is less. So we have this immediate change that happens in the room every time we do a hydrodissection, and we have this kind of slower change that happens over maybe a week or two after the hydrodissection, as the pressure is off the nerve starts to function better. And the other issue is, for that first week, is when we do this hydrodissection, we're kind of breaking those connective tissue adhesions. It can be a little bit bruised feeling for a week, so sometimes it's hard to say, well, was it all the way better? Was it a little bit bruised? What really happened after a week? That usually after 3 days, but it could after a week at the most. That pain from the hydrodissection, kind of a little bruised feeling, which is usually not anywhere near the level of pain you have from a compressed nerve. So that little bruised feeling goes away, and we know, hey, this is kind of where we're at. So we may come back in a couple weeks and do more if needed. And if we address the problem completely, then maybe we don't have to do another hydrodissection. So the question that always comes up with hydrodissections is this something that I'm going to have to do every so often? Or is this something that's, kind of a one and done? And the answer is, like anything else, a lot of times it can be one and done, but typically the nerve gets compressed in multiple areas, so that we think on average it's going to take us about 3 times to completely handle that issue. The other thing that comes up is there's adhesions there, the nerve is being impinged. Why is that happening? If there's continuous inflammation or injury in the area, we can decompress it, and we're going to have to decompress it again, because we know those adhesions are a reaction to inflammation and pain in the area. So if there's arthritis, if there's a muscle tear, if there's a tendon tear that's not healing and it's close to the nerve, we're probably going to have to come back and address it. That said, if there's a tendon tear, a muscle tear, or arthritis in a joint, when we look at that situation, we're always thinking, now that we have this knowledge, is the pain coming from the joint? Is the pain coming from the tendon? Is the pain coming from the ligament? Is the pain coming from the nerve? I didn't mention muscle, because muscle doesn't have much sensation for pain. So when we get muscle soreness, what we're feeling is where the muscles are irritating the nerves. So I want to add a little bit of an extra note to this hydrodissection, and say that it's not just nerves in that area. Sometimes we're hydrodissecting the entire neurovascular bundle, so we're just pushing the connective tissue off of not only the nerves, the arteries, the veins, the lymphatics. So one of the most important things that can be done with hydrodissection is hydrodissecting the neurovascular bundles in the place is where they will get caught and cause edema and swelling. So this swelling and edema is what happens in an extremity typically, where the fluid can go down, but it can't get back out of the extremity. This happens a lot of times after surgery, after combat trauma, after cancer surgery where lymph nodes are removed. So the old idea is we just have to do this massage, just do these things on a regular basis. That's all good and well, but it's not nearly as effective as opening up the drain. So we hydrodissect, in the case of the leg, where the femoral nerve and the artery and vein come in through that femoral triangle. Maybe we'll hydrodissect, the Hunter's canal, where the artery and vein are passing, from the front of the thigh to the back of the thigh, or the popliteal space where the nerve, artery, and veins are splitting and passing through the back of the knee, or even soleus canal, where the arteries and veins are passing from the back of the knee back to the front of the leg. So we have another thing called Tarsal Tunnel that we may have to hydrodissect to help things drain out of the foot. So we just kind of look at what's the reality, where's the swelling, and we're able to address not only these nerve compressions but these neurovascular compressions. And you think about that that flow of fluid being returned out of an extremity. If we could open the drain to help the veins drain out of the extremity, and also help the nerves. So the lymphatics. The lymphatics tend to be wrapped around the arteries. So as the artery pumps, it moves the lymphatics. But if there's compression in the area, both the lymphatics and the venous flow is slowed. So typically what will happen is somebody has had, edema in a leg for maybe decades. We hydrodissect the catch points in those neurovascular bundles, and the next morning they wake up with a leg that's not swollen, or swollen significantly less than it has been in years. So that's what we expect. I first learned of the effectiveness of this neurovascular hydrodissection from a doctor who's probably the most important doctor in combat medicine in the past few decades, Dr. Sean Mulvaney. So we were treating some operators coming back from tough places to be where they've had injuries, and after you've been shot in different places, then obviously you're disrupting the lymphatic flow. There's a lot of scar tissue. It's not unusual for that extremity or that part of the body to be very swollen. So, and in the combat world, they found that, hey, this hydrodissection makes a big change. And what we found is, as a result of working with those issues, is, hey, other people get these issues if they had cancer, where the extremity swells. Maybe they had breast cancer and they had some lymph nodes removed, so the arm gets swollen. Maybe they had a pregnancy that was difficult and they had a lot of vascular hypertrophy or varicosities. So then there's more veins in a smaller space and it's harder to get the fluid through. So maybe somebody has had a surgery that's eliminated or contracted those fascial drainage points. So we need to hydrodissect that. So it's post-surgical, post-cancer, post-combat. This hydrodissection of extremity, neurovascular bundles for extremity edema, or edema in general, is essential. And now we're looking at a very small group of people that have access to that care. So we're offering access to that care. We do that, and we're teaching people as much as we can, as fast as we can, to learn how to take care of these problems for people that are suffering.
What exactly are you injecting? Is there any side effects?
Yeah, well, we generally inject with things that are relatively benign. There's different doctors inject different things. Now, I'd say the most common thing and the most studied thing to be used for a hydrodissection would be a 5% dextrose solution, which is sugar water that would be administered in an intravenous solution, along with a small amount of lidocaine and a even smaller amount of a corticosteroid dexamethasone. So we're looking at less than 1 milligram of dexamethasone and less than 0.1% of lidocaine. So the lidocaine at 0.1% is not enough lidocaine to make somebody weak or numb, but it is enough that the procedure is a little bit more comfortable. So it's not a very painful procedure with lidocaine. A lot of people will do the same procedure without lidocaine. It's just a little bit less comfortable, but also very effective. It's not atypical for people to use more complex solutions like platelet-rich plasma for hydrodissection, placental matrix included in that hydrodissection solution. Saline is often used in that hydrodissection solution. So, and there is a mineral balanced saline that some doctors will use. So there's all these different options. But the bottom line is we're making a structural change. So you can put some super juice in there and everything's going to recover really fast. It's going to cost more money, and it's not always needed. Or you can do the basic, dextrose hydrodissection. The reason we would use a little bit of corticosteroid, usually like a very small microdose, maybe 1/20th of a dose or less that you would get if you got a steroid shot, is that that small dose of corticosteroid sometimes will prevent that inflammation and those adhesions from coming back. So we want to prevent that from coming back. If we use something that's like placental matrix, that's probably even more effective because it stays in the area for a longer period of time. In the case of nerve roots, we are very careful not to use, or when we get closer to the spine, not to use anything that has a particulate nature to it. So it could get into a small vessel and cause some blockage to parts of the nervous system. And so we use things that are safe in that area. Side effects would be bruise feeling, soreness. Probably one of the most, it's not very common, but the most typical thing that would happen is you get a little hematoma, a little blood vessel around the nerve. So if on very rare occasion you feel worse after a hydrodissection, it usually means that there has been a little blood clot or a clump of blood that developed after the hydrodissection around the nerve. In that case, it is not a big problem. All we have to do is go ahead and do actually another hydrodissection, carefully avoiding the vessels to push all of that little clot off of the nerve, and you'll feel better right away. There is always a chance of the nerve becoming injured. Now, of course, when you have the skill and you can see what you're doing, that becomes very, very unlikely. Anything else?
What's the amount of downtime after the procedure?
After a hydrodissection procedure, I think there is, so far as regular life, like walking, driving, those kind of things, not really much of a downtime at all. But so far as getting back to exercise, I usually say, well, definitely don't want to do any exercise or anything strenuous for the first 3 days after the procedure, because the procedure may have put a little bit of inflammation on the nerve. The nerves maybe are not as coordinated as they could be, so you're a little bit vulnerable. We want to keep you safe. And the other thing is that when we do work out and exercise, we do cause a little bit of inflammation, and then actually a lot of times the hydrodissection will feel like you've worked out a little bit, like your muscles are a little bit sore. So when we add that inflammation that naturally occurs from exercise, it could cause those tissues to readhere around the nerve, and that's what we don't want to have happen. So we would say, hey, let's not exercise, for 3 days, maybe even 7 days, until the soreness from the procedure is gone. So we don't add the inflammation or soreness from the exercise on top of it and get the potential for the development of adhesions or strings between the connective tissue that impede the nerve's ability to move.